to play. So, beginning with today's IC, I would like to invite my first speaker, Dr. Arundhati Tamuli, a prolific phacosurgeon and a cornea consultant from Assam. She is the Chief Medical Officer of Lions Eye Hospital, Dibrugarh, and she heads the cornea department of Apeksha Hospital, Dibrugarh. She'll be speaking on pearls for a more stable anterior chamber. Over to you, Dr. Tamuli.
Thank you, Jayashree. I'm Dr. Arundhati. So today I shall try to simplify the principles to maintain a stable anterior chamber in phacoemulsification. But before that, I want you to realize that phacoemulsification is not a static process. It's a dynamic process. A stable anterior chamber doesn't just mean being still. This is something you can imagine of a tightrope walker who always try to balance itself by doing slight movement in order to achieve its goal. Similarly, in phacoemulsification, we maintain the stability of the anterior chamber by balancing the fluidic system. So in phacoemulsification, the fluid game of phacoemulsification, it has three players: the infusion, wound leakage, and the aspiration. The infusion brings fluid into the anterior chamber through the irrigation line, whereas the other two players, the wound leakage and the aspiration, it take out the fluid out of the anterior chamber. So to maintain the balance and the stability of the anterior chamber, the fluid entering into the anterior chamber must be equal to the fluid exit, so that we can have a normal pressurized stable anterior chamber. But if we see practically, it doesn't happen in an absolute term because small amount of microfluctuation always remain. So let's see what happens if the infusion goes high. The intraocular pressure will be raised. So at that time, we'll see the anterior chamber will remain full with a high IOP, but clinically it won't be evident. But only when there is excessive overpressurization, we'll see there may be jonular stress, aqueous misdirection into the vitreous, and very rarely we may get wound leakage. What if reverse happens? If the aspiration goes high and cannot be compensated by infusion, then we'll get shallowing of the anterior chamber because of the low IOP, and which is clinically evident. Similarly, the same thing happens if there is an excessive wound leakage. We'll get an unstable anterior chamber. But what we have observed, like whenever the infusion goes high, clinically we won't observe. Clinically the things will not be observed. But whenever there is an excessive exit, like excessive aspiration or wound leakage, we'll see it clinically. We can see there is a shallowing of the anterior chamber. So here I want to emphasize that we cannot absolutely avoid the mismatch in a rapidly changing scenario of phacoemulsification. Our aim should be to make it as minimum as possible to have a surgically stable anterior chamber. Why I am saying surgically stable anterior chamber? Just I want to ignore the microfluctuation which always remains. So this is a typical phacoemulsification setup in a peristaltic machine. So here we can see what happened exactly. The fluid first travels through the irrigating line, then reaches the phaco handpiece, then through the irrigation port it enters into the anterior chamber. And from the anterior chamber, the aspirants are taken out because of the revolving nature of the pinching wheel. So here the RPM of the pinching wheel will determine how fast the fluid will drag out of the anterior chamber, and this is called the aspiration flow rate. The same thing will determine how fast the vacuum rise, the suction pressure will build up. In contrast, in Venturi machine, there is no revolving wheel. So here the compressed gas, it creates a vacuum, and this vacuum drags the fluid out of the anterior chamber. So let's see how we can minimize this fluctuation level, how we can make the anterior chamber stable by doing some modification. Number one, what we can do, we can increase the fluid height. So by increasing the irrigating fluid height, the force of fluid inflow will also increase, and this in turn causes raise in the intraocular pressure. And this high in the anterior chamber pressure, it's sufficient to resist the sudden fluctuation which usually we get in case of occlusion break. Second thing, we can modify the exit route. Like if we can reduce the phaco tip size, we can reduce the exit, like we can reduce the aspirant. Second, if we make an incision which corresponds to the size of the phaco tip sleeve, we can reduce the leakage, because when the leakage will be more, there is more chances of shallowing of the anterior chamber. Third, in case of peristaltic machine, we should keep the RPM as low as possible. This is because this determines the AFR. So when the AFR is raised, all the events that takes place in the phacoemulsification, they will also go in a faster space, whether it's a vacuum, it's a rise time, or the surge. So it's important that we should keep the AFR in a minimum level so to avoid any untoward accident. But in Venturi, as we don't have any RPM, it's the vacuum limit which we take into consideration. The vacuum limit is something which prevents the vacuum to rise beyond a preset level. Because if there is more vacuum, there is more chance of fluctuation rise, especially after a sudden occlusion break. So these are the modifications which we can do to maintain the stability of the anterior chamber. So let's see what the innovators are doing in this newer generation machine to reduce the fluctuation to a micro level. So first is the positive pressure infusion. The BSS, here they have earlier, like air was insufflated into the bottle in order to create a positive pressure. But nowadays, the many phaco machine, they have a compressed bottle. This compressed bottle are guided by a sensors that senses the intraocular pressure in the anterior chamber, and thereby it's maintain the IOP to a desired level so that surgeon can work comfortably in any scenario. Second, replacing the rubber tubes which are very malleable and compressible by replacing the rubber tube by a silicone tubes, which are the rubber tube are considered very malleable and expensive. So any fluctuation, if it's there in those rubber tubes, it can be transmitted easily into the anterior chamber, so thereby affecting their stability. Third, there are machines which have got enclosed peristaltic machine in the cassette, and these are found to be very effective in controlling and dictating the fluidics in the anterior chamber in a more precise way. So there are lots of innovations that have been done in many phaco machines, like fluid bypass port in the phaconeedle, surge suppressor device, and there are surgeons who use additional infusion port, like by using anterior chamber AC maintainer in order to stabilize the anterior chamber. So at last, I would like to say every surgeon has its own unique surgical style. Understanding the fluid game to the core will let one tune the machine to his style of surgery. We then don't have to memorize the phaco parameters as a company set confusing data. Thank you.
Thank you, Dr. Arundhati, for covering this topic so well. And definitely now we have understood that how we can maintain a stable chamber during phacoemulsification. Now, how do we deal with when we have some variations in our eyes? This is what we have in a normal eye. Now, speaking on the next topic, we have Dr. Nilanjan Kaushik Thakur, who will be speaking on hydrodissection in eyes with shallow anterior chamber. Dr. Thakur is a very dynamic surgeon and a very good teacher who is working presently at Silchar Medical College and Hospital, Assam. Over to you, Dr. Thakur, for your presentation.
Thank you so much, Dr. Jayashree. Good morning, everyone. So slides will be repetition of my previous speaker. So it's a hydrodissection in eyes with shallow anterior chamber. So we all know it's a challenge during the cataract surgery, and it already reduces the tight confines which we get while doing the surgery in the anterior chamber, if it is a shallow anterior chamber. Now, we should also know that the two most important structures in a cataract surgery are the corneal endothelium and the posterior lens capsule. Now, these are subjected to irreparable damage if there is fluid imbalance in the anterior chamber. So, techniques to deepen the anterior chamber during cataract surgery would provide a wider margin of safety and it helps to ensure an excellent visual outcomes. So before going for the surgery, we should know the risk factors first. So what are the risk factors? So it's a demographic factors are very important, but in Asian populations, like in northeastern some population, we get smaller eyes. In patients with hypermetropia, in patients where there is weakness of the zonules, which will cause the iris lens diaphragm to come forward, okay, and in small eyeballs. So you should be beforehand, you should be careful that these patients might have a shallow anterior chamber. Now, what are the intraoperative clauses? Now, if you are doing the surgery under peribulbar block, be careful about retrobulbar hemorrhage. Now, in some cases, there will be zonular disruptions, and this will allow the fluid to go into the posterior segment. So it will act like a one-way valve. So in patients with pseudoexfoliation syndrome, history of ocular trauma, in Marfan's, in posterior capsular rupture, you should be very careful beforehand that this patient will have problem. You will have problem during surgery. So during surgery, what are the causes that causes the shallowing of the anterior chamber? Number one, as my previous speaker said, there is excessive fluid is going out from the anterior chamber. It's through the main wound or from the paracentesis. Number two, you have put a very high flow setting in the phaco machine, or there is insufficient, less fluid is coming inside the anterior chamber, or the bottle height. As my previous speaker said, the bottle height. So these things you should be kept in the mind. Now, another important point is the positive pressure. So positive pressure may develop. Sometimes you are putting the speculum very tight or the drape very tight. So you have to look into those matters also. Now, proper pre-operative evaluation. In the slit lamp, you can do the grading of the anterior chamber by Van Herrick's method. And when you're doing a biometry with a scan, that will give you the anterior chamber depth. So then you can come to know, okay, that patient will have a shallow anterior chamber. Plus, you can do an OCT anterior segment or an ultrasound of the anterior segment. Now, what are the management strategies you like to do before proceeding for hydrodissection? Now, if you feel that you want to decrease the vitreous volume, you can use mannitol. You have to see the other parameters like BP and all you should see for check before giving mannitol. Now, if you want to decrease the aqueous volume, you can go for oral acetazolamide tablets. Now, if you are doing under peribulbar block, make sure that you give a very good block, because a good block will have a very good ocular echinacea, and that will decrease the chance of pressure from the eye muscles. Number two, avoid large volumes of local anesthesia, because that will increase the intraocular pressure and it will complicate your scenario. Now, a good ocular massaging is very important because this will reduce the orbital volume, okay? And just minimize the pressure, external pressure, like the drape, the speculum, tight speculum, and your handling should be gentle. Now, if your paracentesis wound is leaking excessively, give a suture over there. If your inflow is insufficient, see the sleeve, or you can enlarge the incision. Now, if your bottle height is inadequate, raise the bottle height. But see, if you raise the bottle height, the pressure is more, the patient will complain of pain, okay? So you can decrease the flow rate. Now, if you have eliminated the above causes and still the chamber is shallow, you can see with your finger the tightness, then you have to rule out other causes. You can use high viscoelastic substances to create and maintain spaces. Now, coming to the hydrodissection proper. Now, performing a hydrodissection is difficult in the anterior chamber because due to the poor maneuverability, continuous collapsing angle, and it can be further complicated if the intraocular pressure is rising or there is iris prolapse from the wound sides. Now, what are the important tips to keep in mind during hydrodissection? Number one is the placement of the cannula. The cannula should not be over the capsule. It should be beneath the capsule and you should tent it. Okay, this is very, very important. Now, if you are injecting fluid over the capsule, if your zonules are weaker, sometimes it acts like a one-way valve where the fluid will go into the posterior segment and that will collapse the chamber further. So this is a condition, so immediately you have to give mannitols or you have to manage it. So there you have to be very careful. Now, amount of fluid and the intensity of fluid, it should be in a controlled fashion and slow. And important thing is that you should see that there is no air in the syringe. Okay, sometimes you put air is there before hydrodissection, just you push, air will go inside, so that will cause PCR. Now, you have done a small capsular excess. You have to be very careful because once you inject fluid over here, it will push the nucleus upward and it will cause anterior capsular block. So here you have to then tap on the nucleus and the amount of fluid injected, because if it is a small capsular excess, fluid will collect there. If the amount of fluid is more, it will then the PCR will occur. It will rupture the capsule. So this is intumescent cataract that will cause shallow anterior chamber. Do a big capsular excess and do the hydrodissection tap in the middle. Okay, so this is one conditions. Another is, so this is a mid dilated pupil. You're not seeing the capsular excess margin. Be careful. Just try to identify the rhexis margin and try to put the fluid underneath the rhexis margin. So you have to be a little bit extra careful in this type of patients. Now this is which I got in the literature is a phaco sleeve assisted hydrodissection. So what they have done over here is that they block the main incision site with the phaco sleeve and they don't remove the viscoelastic substances. And the hydrodissection is done from the side port. I usually do from the main port. I don't do from the side port. So this is a steep learning curve. How successful, it's difficult to comment now, but they do in shallow anterior chamber. So the key to successfully completing hydrodissection and cataract surgery in the presence of a shallow anterior chamber is recognizing the problem early. Do a proper preoperative workup, making a correct diagnosis, see if it is not having any zonular lysis, all those other conditions you have to rule out, and you have to recognize the problem early and make a correct diagnosis, thoughtfully assessing one's options. Then you can think what I can do in the table. Okay, so then thereafter proceeding with a suitable management strategy. Thank you so much.
Thank you, Dr. Thakur, for that wonderful presentation. I would like to request our audience to, if they have any questions, just to jot them down and we'll take up the questions at the end of the session. So coming to the next talk, and next talk is by Dr. Mayur Bharali. He is presently working at Nalbari Eye Hospital at Nalbari and Guwahati, Assam. So he'll be speaking on fluid loss through side port and chamber instability, another difficulty that we encounter while doing our phaco surgeries.
So thank you, Dr. Jayashree, for giving me this opportunity. So today I'll be talking on fluid loss through side port and making the chamber unstable. This is normally we overlook in whole of fluidics, thinking about vacuum pressure, infusion pressure and all those things. But there is one thing which occurs normally, there is a fluid loss through side port. This video we can see, I have zoomed it towards the side port only. See, it's look like a leaking tape. In our home, if this occurs, we will have to call a plumber for this, but we are proceeding with a phacoemulsification in this case with so much of fluid, whatever infusion is coming, all of it's going outside through the side port. If you can see, I have zoomed it to the side port. So what is the background? Phacoemulsification nowadays has become most preferred technique for cataract removal. It involves ultrasound and a fluid flow, the fluidics. That is most important in case of a phacoemulsification. Fluidics is a term used to describe the balanced fluid flow, inflow, outflow, and a balance between the two is most important to keep the anterior chamber stable. This is a very raw diagram. We can see a phacoemulsification machine in the center, and it is a gravity-based fluid. So it is fluid is up. The fluid comes through the machine, goes to the eye. It should come out through the aspiration port to the machine again to the drain bag. But if this fluid bypasses and it comes out like the video I have shown, that is fluid loss through the side port. So modern phaco machines either have a very peristaltic or venturi machine already described by Dr. Arundhati. So BSS running out and excess pump speed, these are the two important causes of chamber instability or the chamber collapse. So fluid flow related issues are like surge, vacuum loss if it occurs, that occlusion breaks, post occlusion surge, and the PCR most commonly. Fluid loss through the side port causing chamber instability is normally overlooked, and it is an important factor which is not given its due. So what are the important fluid flow related issues? First of all, that the fluid is important to maintain the IOP. Proper fluid flow ensures that the chamber remains deep and stable. Then visualization of the surgical field, which is also very important to remove the debris. Our cornea should be wet, or inside whatever debris in the AC, we have to remove it. So that is also important for fluidics. Then control of lens fragmentation. The fluid should come to the probe, phaco probe, and it should goes out, not the other way around through the side ports or the main port. In fact, main port, some amount of fluid leakage should occur because it keeps the wound, main incision wound, and it avoid the burning of the wound also, but not through the side port. And then it helps in lens fragmentation and prevention of complication, and by maintaining the proper anterior chamber. So fluid flow is critical for the success of phacoemulsification surgery. Now, incision fluid loss. The anterior chamber can be viewed as all practical purposes as a closed system between the atmospheric pressure and the posterior vitreous pressure. So anterior chamber is primarily influenced by the balance between the influx of irrigation fluid and the efflux through the main or the side ports. A fluid loss through the side port incision can cause disruption, and two of the important pressures which is related to the fluid flow is the vacuum pressure, that is the negative pressure, or the suction pressure. It disturbs when the fluid goes out through the side port, or the infusion pressure, that is in case of a gravity based infusion from the bag, fluid coming from the infusion bag, or in a active fluidics where like a higher end machine like Centurion, where the infusion pressure is maintained by those plates pressing over the bag. So proper side port size is very crucial in maintaining the fluid dynamics. It has been calculated that about 67% of the fluid which is used during the phaco surgery is lost through the side ports, and we overlook that. Fluid loss through the side port can occur due to poorly constructed wounds. The side port should be suitably sized for the second-hand instrument. Whatever the size of the second-hand instrument, sometimes we use those iris spatula or blunt. They can be bigger, smaller. So we have to look whichever instrument we are using, our side port should be there. And sometimes removing the second-hand instrument before removal of the last fragment is helpful also to make the chamber stable. The size of the side port is directly related to the fluidic stability of the anterior chamber. If the side port is too large, there is a risk of excessive fluid leakage and leading to a decrease in the intraocular pressure or subsequent chamber instability and complication. But on the other hand, if the side port is too small, there is a risk of insufficient fluid flow leading to increase in the intraocular fluid pressure, subsequent chamber instability. A smaller side port can provide better fluidic control, but may limit the instrument maneuverability, while a larger side port can provide more instrument maneuverability but may compromise the fluid control. The side port should be constructed properly. The size of the incision should be appropriate for the size of the IA probes also used. So IA probes are different gauge IA probes we get. The proper appropriate instrument should be used. Other factors like vacuum setting, phaco power, irrigation should be carefully monitored and adjusted. If the fluid loss occurs, we should stop the surgery immediately. Now, if it occurs like my previous video, if it is occurring, then in that scenario we should stop. We should not use that side port, and we should make another side port from another paracentesis, and then we should proceed. Sometime we have to close that side port also by giving incision. So in summary, fluid flow is critical to the success of phacoemulsification surgery. Proper management of fluid flow ensures a stable intraocular pressure, a clear surgical field, efficient lens fragmentation, and prevention of complications. So it is important to have a thorough understanding of the fluidics. Then regular monitoring of the IOP chamber instability during the surgery also helps the surgeon to identify the fluid related issues. So I'll go to this video actually to the last. You can see this is a normal case. What we should do and we shouldn't do. Normally when manual surgeons convert to phaco surgery, then what happens is that we use normally 15-degree side ports, and we have a habit of just increasing to the side. So we should not do that, and we should use these 1 mm side ports that directly give us only 1 mm incisions. So in this case, already side ports are made. I'll not show the rhexis part and hydro part, etc. But see, now the second-hand instrument is being used after the phaco probe is inserted. See, there's a very less leakage or to no leakage actually. So in this scenario, there is no problem to progress with phacoemulsification, and normally we don't look for these side ports, and our whole concentration is in the nucleus removal. This is another case. If we can see now, same I have made 2 paracentesis or side port incision using these type of blades are good actually, and no sideward movement. So normally what happens is in manual SICS, we need those sideward movements to put, because we have to think about putting the Simcoe also. But in this case, we don't require, so we shouldn't. So already rhexis is done, hydro is done. This is a mature white cataract, and it doesn't look soft because a brownish tinge is coming from inside. Now see, there is a leakage in this case. If you can see here, yeah. So there is leakage in this case. But this is I am doing in a Centurion where active fluidics. So normally these machines take care of those excess fluid loss by pressing the plates more and maintaining a stable IOP. So fluid loss is there, but still we can go through the phacoemulsing procedure. I am doing direct vertical chopping. That is routine. So not thinking more about that fluid loss, whatever is happening till now. I'll just make it fast, the nucleus removal and all. And due to the fluid loss, you can see there is the visualization is also a problem because of the water over. Now the last piece removal is there. Normally otherwise there is no problem would have happened with that fluid loss, but because my fluidics is already disturbed due to the side port fluid loss, and suddenly I have this last piece removal, there is a PCR. So I don't come out, which is a dictum. In case of PCR, we don't come out. I put the viscoelastic from the anterior chamber, but still these are common things. So yeah, so side port fluid loss is important, and we should not overlook this condition, and it occurs more frequently than not. Thank you very much.
Okay, thank you, Dr. Bayur.
Now, Dr. Swaraj Bhattacharya is not there, so Jayashree will be speaking on flow issues after posterior capsular rupture. She is the director of Sight Plus Hospital in Jorhat, Assam, and another prolific anti-segment surgeon.
Thank you so much, Dr. Arundhati. So now I'll be continuing with what Dr. Mayur has ended, a PCR. So this is a complication that we all fear, we all dread, because when you're in a busy OT, you know that this is going to eat a lot of your time. So why do we need to understand the flow issues in PCR? Posterior capsular rupture is something that is associated with your vitreous loss that is responsible for 40% increased risk in the retinal detachment. And most of the times it's not because of the PCR, but how you deal with the PCR that causes more of a problem. So if we talk about the physics of PCR, we have 2 separate chambers, right? We have the anterior chamber and the posterior chamber, and in between we have a membrane. Now, following the fluidics, the flow of the physics of fluids, always there will be the flow from the high pressure zone to a low pressure zone. Now what we are doing a phacoemulsification in an anterior chamber. We have a negative suction pressure, so your vitreous will come from a posterior chamber directly into the anterior chamber, and following the rule that it follows the least resistance. So where will be the area of least resistance? It's your wound, so it will ultimately come out through the wound. So this is what we have to keep in mind. Now, in the causes of PCR, no doubt there may be some inherent causes of PCR, like you are dealing with a PPC with a pre-existing dehiscence. It may be because of your faulty technique. You're learning, and even if you're not learning, sometimes you may go wrong in some steps, and that might be responsible for PCR. But what is more responsible for causing the complications of PCR is the phacodynaamics and the psychodynamics that is associated with PCR. You know that you have a long list of patients, you try to manage it. Jaldi karna hai. But that's not the way. You have people watching you in the OT. They know that you are a brilliant surgeon. You have to let your ego come down. You have to manage the case. So now every single step is important, starting from your incision. As we have already discussed, even the tiniest of the side port leak may lead to a shallow anterior chamber that may be responsible for your rupture. And even the last step, like the IOL insertion, there was recently a video that was circulated in most of the groups. You have a foldable IOL being implanted and the IOL is not to be seen. It was an intact BC, it just shoots into the vitreous cavity. So you may have instances like that. And you have to be very careful with the second instrument. Most of the times we are concentrating on our phaco handpiece. We are concentrating on our right hand instrument for the right-handed person, but we have another instrument that we are dealing with our left hand. So we have to be careful about that. So these are two videos where the last piece, phacoemulsification, ended in a PCR, and secondly, even in case of when you're doing a simple IA, you may end up in a PCR. So a stable anterior chamber is a must, and that has been wonderfully dealt with by my first speaker. So we know how to maintain a stable anterior chamber now. But there are three intraoperative situations that we might encounter. First is we just see the wrinkling of the capsule. Yes, you know that there is a PCR, but then you have an intact anterior hyaloid phase. The second case is when you have the vitreous prolapse. That means the vitreous coming from the posterior chamber to the anterior chamber. And the third is the situation is when you're having a vitreous loss. That is, it crosses even the anterior chamber, it comes out of the anterior chamber. So these three stages might be complicated by the fact that you still have the retained nuclear material or the cortical material to deal with, right? So now, what will be our response? You might not realize that there is a PCR. You keep on continuing your phacoemulsification. You realize that there is a PCR. You panic and just come out. And, oh, there is a PCR. Or you take a deep breath, you think, and you try to think what were the steps that were taught in the first talk that we had. So you plan out your agenda, and using your appropriate techniques and settings on your phaco machine, you can definitely give good results to your patients. So we have a new set of goals now. We have to prevent the vitreous loss. We have to keep our rexis intact so that we can implant the IOL and complete the case now. So this is, if I want to ask you, what is the single take-home message from today's talk, it is that you need to avoid the vitreoretinal traction. No active phacoemulsification when you diagnose a PCR, because the phaco probe is a very good aspirator. It's a very strong aspirator, but it's not a cutter. So it can aspirate and it will separate your neurosensory retina from the RPE. And this RPE pump pressure, is just 0.27 millimeter of mercury. So it's easily overcome. So you have to avoid phacoemulsification. First, early detection is very important. For this, just the 3 R's by Dr. Howard Fine. You see that suddenly there is increased space. You have enough space for performing phacoemulsification. You see that the pieces that were coming to the center with your second instrument is not coming smoothly, and you feel some resistance. Phaco was being performed well, but you feel some resistance, and sometimes you may hear the occlusion sound even when there is no nuclear material occluding your phaco tip. So at the very suspicion of PCR, you need to stay calm, and you need to signal your team without the patient knowing that yes, you have had a PCR. So they have to be ready with whatever essentials that is required, including the lowering of your parameters. Don't take out any instrument, don't move any instrument, just go to foot position 1 and stop your phacoemulsification, continue the irrigation. And your assistant must know what are the things that you'll require now. It's not that once you have the PCR, then you go about searching for your vitrectomy consumables. It's not like that. It's something that you have to keep that vitrectomy kit. It's a must for every phaco surgeon. You need the vitrectomy consumables. You need a separate set of SICS, ECC instruments, since you might need to convert the case. You require a dispersive viscoelastic. You need triamcinolone to stain your vitreous. You need pilocarpine and an IOL of appropriate power that might be required to replace it. So these are strict no. That is, once any nuclear remnant has crossed your PC and reached the posterior surface, don't hesitate to give the case to your vitreoretinal colleague. Because we have a tendency that no, I don't want to send him to a retina colleague, so we go about fishing. We go with a phaco probe into the posterior capsule. That's not allowed. You cannot use any instrument inside, because any amount of instruments that you are using and the traction which you are using is sufficient to cause your retinal detachment. And don't think that the fluid will lift up your your nuclear pieces. No, it will not do. It will work in AC. It will not work in the vitreous. So no amount of irrigation like in the third picture is going to work in this case. So go slow and stepwise. First, maintain the pressure gradient, which is the most important point. Then deal with your nuclear fragments, do a good vitrectomy, and complete the case. Now, do not let the interior chamber collapse at any moment. So, as I have already mentioned, don't take out any instrument. Just take out the the second-hand instrument that you are holding. See, there is a PCR in the last moment. So, inject the dispersive viscoelastics. This will do two things. One, it will float your nuclear pieces upward. And secondly, it will give a protection. It will form a seal over your PCR. So remember another thing, that viscoelastics are cheaper than your vitreous. Don't hesitate if you need to use even 2 bottles of dispersive viscoelastic. This is a very important point because it will prevent your cataract pieces from falling back into the vitreous, and it will prevent a long-term complication that the patient might have to go through. So the same thing here, just take it out and just inject your dispersive viscoelastic, and only once the chamber is fully formed you can take out your phaco probe now. So this is what I have already said. One is we seal the rupture area, and secondly the pieces, they float up, and then you can go for the management of the nuclear pieces. If you are in a doubt that whether the vitreous has come out or not, whether there is actually vitreous loss or not, this is another strict no, because again, where you are causing the traction, where the adhesions are more, that means you are causing a traction at the vitreous base. So this is again not allowed. You have any doubt, go for triamcinolone. It is easily available, it is cheap, and it will help you to detect the vitreous very clearly. So triamcinolone, even at the starting, when you are starting the vitrectomy, and also at the end after completing your case, just to find out whether the vitreous is there or not, use a separate incision for your vitrectomy. Now, as regards to whether we should go for coaxial or bimanual, yes, my preference is a bimanual, because here you have the irrigation port above and you have the vitrectomy probe which is working down there. But in coaxial, you have it at the same point, so it's hydrating your vitreous as well. So this is paracentesis anterior vitrectomy, but we can also go for the pars plana vitrectomy because this is more physiological. This is the vitreous stays where it is actually supposed to stay. So most of the machines, they have 2 modes of anterior vitrectomy. We have the cut IA to remove the vitreous and the IA cut to remove the residual lens matter. The difference between this is that in cut IA, you have irrigation. In foot pedal 2, you have the cutting, the vitrectomy, and in position 3, you have the aspiration. Only after cutting the vitreous, you will have to aspirate it, and not the vice versa. I'll just take 1 minute more. So regarding the parameters, in cut IA, we have to take the highest cutting rate that is allowed in the machine. So in conventional machines, it is 1500 to 2500 cuts per minute. But in cases with the latest machines with active fluidics, you can go up to 5000 cuts per minute. So the more is the cutting rate, the easier is the vitreous removal. So the same thing, the vitrectomy is in progress. And I would like to mention that this movement with the vitrectomy tip that you see, it's only at foot pedal 2 when you're doing the cutting. So IOL implantation will depend upon your residual capsular margin that is there and the residual nuclear material that is there. You might need to enlarge your incisions. And for the IOL implantation, if it's a small PCR and you know that you can still go away with the foldable IOLs that you had planned. Otherwise, a 3-piece IOL as seen in the second case with the sulcus fixation is it's what is suggested in most of the cases, or you can go for a rigid PMMA IOL. So another thing is that at the end of the case, please don't forget to give a suture. Retropupillary iris claw lens is another important alternative that can be observed as a very good alternative to SF-IOL. Here, all you need is to extend your incision, and I am just showing this video for the greater interest of all the people, so that if you don't have a facility for a SF-IOL, you can easily go for this types of IOL where you just need to nick the iris tissue into the haptic gap that is present, and that's fine. And then at the end of the surgery, you have a perfect retropupillary iris claw lens like a PC-IOL itself. So post-operative course is a bit longer, but using these appropriate technologies and settings in our phaco platform, we can optimize the situation and minimize the vitreous loss. Thank you so much for your patient listening.
Excellent and well covered, Dr. Jayashree. Now, I would like to call upon Dr. Swaraj Bhattacharjee. He'll be speaking on dealing with reverse pupillary block. So he is heading the Lakshmi Eye Hospital in Tinsukia, Assam. He is also a prolific anterior-segment surgeon. Over to you, Swaraj.
Good morning, everybody, and thank you, Dr. Jayashree, to include me in your instruction course. And greetings from Assam. My topic is dealing with the reverse pupillary block. No financial interest, of course. Normally, the pressure in the posterior chamber exceeds that in the anterior chamber due to the physiological degree of resistance at the pupil. Since the iris rests posteriorly on the anterior lens capsule, so there is a normal flow of fluid from the posterior chamber to anterior chamber. Before speaking out about the reverse pupillary block, we must know what is relative pupillary block. There is anterior iris bowing where the pressure simultaneously dilatation of the pupil renders the peripheral iris more flexed. This pupil block causes the pressure in the posterior chamber to increase and the peripheral iris bows anteriorly. Eventually, the iris touches the posterior corneal surface, obstructing the angle and the IOP rays. And just contrary to it, we had reverse pupillary block, where in some situation there is floppy iris and the floppy zonules. Now, pushing the BSS with the cannula, the pupillary edge compresses against the lens. There develops a compartmental syndrome. The anterior chamber pressure increases, which makes the lens to be pushed posteriorly. In some situation where the reverse pupillary block may occur during cataract surgery, which includes high myope, post-vitrectomized eyes, and the young patients who are undergoing surgery. Pseudophakic reverse pupillary block may occur in patients even with a pupillary optic capture in the sulcus fixated IOL. The clinical scenario in the reverse pupillary block: first, there is posterior displacement of the lens iris diaphragm, marked deepening of the anterior chamber, posterior iris bowing, pupil dilatation, and ultimately leading to the significant patient discomfort. The reverse pupillary block causes the lens iris diaphragm syndrome, which begins when 360 degree of the iridocapsular contact occurs, which is called as lens iris diaphragm retropulsion syndrome, or LIDRS. Now, this reverse pupillary block are seen while doing the hydrodissection during introduction of the irrigation port, and remember, it happens every time when we enter, and more with the use of the dispersive viscoelastic like Hilon 5, Viscoat, etc. Now, the management of the reverse pupillary block, how to prevent it? Preoperatively, proper history taking. We should look for the myopic patients. Are there? Meticulous biometry, to use the new generation formula, proper fixation to get the accurate axial length. Intraoperative, we should have a low IOP phaco, low bottle height, and low irrigation setting. Now, what to be done in the actual scenario? Separating the iris from the anterior capsule rim with the IA tip, the phaco tip, or any available instrument, which equalizes the pressure between the anterior chamber and the posterior chamber, results into the iris will immediately return to the more physiological position. As the iris root and the zonules are attached to the ciliary body, lens will also return to its normal position and ultimately the chamber reassume a normal depth. Any degree of discomfort the patient was experiencing from the syndrome will dissipate once this situation happens. This has some cons also. The pupil will decrease in the size. If the ciliary body has been stretched for a period of time, the pupil may begin to become more myotic due to the release of prostaglandin upon stimulation of the ciliary body. A word of caution in the myopic eyes, which carries a higher risk due to the larger anterior chamber volume, which affects the phacoedynamics. Posterior chamber volume is also increased, creating greater aqueous humor flow into the anterior chamber. The risk of the tear in the posterior capsule increased, and there is a more risk factor for jonular weakness. Ultimately, all this situation leads to the more and more reverse pupillary block. I like to discuss about a case which was a 54 years male high myope with the axial length to the extent of 27.13 millimeter, NSC grade 2. IOL power came out to be +4 with the target refraction 0. While doing the optical biometry with the IOL Master 700, here we could see the axial length very nicely, 27.13. It was NS2, so it was very comfortably coming. But the difference in the steep meridian and the other meridian, it was minus 2.894 degree. In the other eye also it is same. Now we go for the online hour power calculation with the Barrett Universal 2, and we got a 4 diopter meniscus lens to be the correct power. We are using Alcon Expand series lens in this case. I like to share a small video. The post-operative outcome, we have seen that it has got a very high cylinder. So ultimately, patient got a 6x6 partial vision with 0.50 spherical with -2 diopter, 90 degree. The residual toric component has been covered with the glasses. There was no way out to add a toric lens in this situation. So what are the take-home points? Normally, the jonules and the ciliary body are strong enough to resist excessive posture displacement. Still, in some situation, reverse pupillary block occurs. Adequate pre and para-operative measures helps to manage the situation comfortably. Armamentarium must have a backup IVL CTR if the situation demands. Thank you so much for a patient hearing.
Thank you, Dr. Swaraj. Indeed, that was a wonderful video, and I think I can see a few young ophthalmologists out here, so they might have learned a lot from this presentation. So next we have another presentation, role of fluidics in post-vitrectomized eyes by Dr. Manas Nath. He is another wonderful surgeon. I am sure everyone will love seeing his videos. So over to you, Dr. Manas. So this is the last talk of this IC, and since we are running short of time, maybe we'll just take up one or two questions, and if anyone has any queries, all our instructors, co-instructors are available for discussion anytime, maybe in the IT area.
Maybe little less if possible. 40 is the standard. Nowadays you are using with 40 only. So maybe
That's what I said, that it can come down like lower also.
yeah, 30.
Maybe even lower.
Even lower. Okay. We'll try it.
Okay, Dr. Manas.
Yeah, thank you, Dr. Jayashree, for giving me this opportunity. So I'll be talking about role of fluidics in post-vitrectomized eyes. Parsplanal vitrectomy is now a frequently performed retina surgeries, and for the last decade, the visual outcomes are quite promising because of advancements in the machine technology and the surgical technique as well. But there is a risk of cataract progression in up to 80% of cases within 2 years, and there is definite role of anti-segment surgeons to play because this extra burden will definitely fall on them. So phaco after PVV is always challenging, not only because the cataracts are harder and denser, but also it is associated with some syndromes like lens iris diaphragm retropulsion syndrome, which has already been discussed by our previous speaker. So here, as the vitreous support is not there, as soon as you introduce your phaco probe inside and press the irrigation foot pedal, there will be certain deepening of the anterior chamber, as you can see here, and one is to bend the phaco tip too much, too acutely, to reach the surface of the nucleus. So in that, there will be stretching of the iris leading to pseudopupillary dilatation, stretching of zonules, and posterior displacement of the iris lens diaphragm, and it can lead to severe ocular pain if it is done under topical anesthesia. And as per Dr. Sioni, he published his technique in 2004 in JCRS. Here you just have to lift your iris with any instrument so that the balance will be there between the anterior and posterior chamber, and the chamber will become relatively normal. But in doing that, the pupil can become relatively small and the surgery can become a little bit complicated. There can be chances of posterior synechia, zonular damage, and even posterior capsular tear. Here you can see that there is a linear capsular opacification suggesting a lens touch during your retina surgery. Capsular access can be difficult because as the vitreous support is not there, one is to put a little bit of extra force to initiate the capsular access tear, and sometimes the entire capsule will be too much, there will be too much of fibrosis. And infusion deviation syndrome is not very uncommon. And even your silicon oil in the anterior chamber is always associated with poor visual outcome because it hampers with your preoperative and intraoperative procedures, and itself it can damage the corneal endothelium. And if you see a cataract, total cataract like this immediately after your retina surgery within 3 or 4 weeks, one should suspect a posterior capsular dehiscence. Proper history taking is very important because one has to be clear that this present visual loss is because of cataract and not because of the pre-existing retinal disease. Biometry is also very challenging. I am not going to talk about biometry here because it is out of the scope of this IC. Thorough slit lamp evaluation is important. Here you can see that there is localized posterior capsular opacification, and on table the surgeon noticed a linear capsular tear. Even a B-scan, AIOC or EVM can be used to look at the integrity of the posterior capsule. Sometimes IOC 700 can also help. Here you can see that the IOC 700 image showing a dehiscence or your loss of integrity of the posterior lens capsule. As mentioned by our previous speaker, the incision should be watertight always, not only side port but our main incision as well. It should not be uniplanar, as you can see here, and making a scleral tunnel will be difficult because of conjunctival scarring from the previous retinal surgery, and clear corneal incisions are preferred. And try to avoid making a very long clear corneal tunnel, as you can see here, because in this case also you have to bend the instrument down too much, too acutely, and where already the chamber is deep because of the previous vitrectomy surgery, it will lead to folds in the cornea, and visualization during the surgery will be compromised. And the altering the phacoeparameters is also very important, as already mentioned by our previous speakers, and to have a reduced AC depth, chamber deepening, one should lower the bottle height, as we know that the balance between inflow and outflow should be there. So accordingly, your flow rate vacuum should be reduced up to a level that you don't encounter surge. And this lowering of the parameters will definitely slow down your surgical speed, but as we know, slow and steady wins the race. Fluid infusion deviation also not very uncommon here. In this case, what happens, as the zonules are weakened because of the previous retinal surgery, the fluid can pass through the zonules and it accumulate in the vitreous cavity and can lead to your positive vitreous pressure, leading to shallow anterior chamber. So it has been postulated that if you keep your phaco tip posterior to the iris plane, the chances are higher of getting deviated towards the vitreous cavity. So in this case, lower the bottle height in case of raising it, and try to keep the phaco tip anterior to the iris plane, and try to avoid doing in-the-vac phacoemulsification if one is experiencing abnormal fluctuations in the anterior chamber. Doing a 20 gauge or a 23 gauge vitrectomy is of no use because there is hardly any vitreous to be removed, nor there is any role of mannitol, as there is no vitreous. So obviously one can put a valve trocar cannula. So here, with the help of this, the fluid can be removed, and once the eye becomes firm, the cap can be placed and the surgery can be continued. Let's see some of the surgical scenarios here. This is a case of a post-PPP surgery done for ERM many years back, and now the patient presented with your vitreous hemorrhage from diabetic retinopathy. And probably because of this light, the image is not very clear. And the glow was not there because of the vitreous hemorrhage behind. Stained the capsule with tryptophan blue, trying to make a relatively larger capsulorhexis for better visualization for the retina surgeon. Hydro dissection will be really difficult here because one will not be able to appreciate the fluid glow. When I'm also not able to appreciate the fluid glow, your fluid wave, it has to be very gentle. So during phacoemulsion, what I do in this kind of cases, I take a spatula in one hand and introduce my phacoprobe in 0 mode, and before initiating the foot pedal 1, I just lift the iris so as to prevent the reverse pupillary block to happen, and which will prevent the sudden deepening of the anterior chamber, and then one can continue with the phaco surgery. The real challenge comes when is doing the bimanual irrigation aspiration. So here, as soon as you introduce your irrigation cannula, you see that there will be sudden deepening of the anterior chamber. So in this case, I just lifted the iris with my another instrument. The chamber became normal, and one can also inject viscoelastics, which will maintain the anterior chamber. And next time when you introduce your irrigation port, there won't be any reverse pupillary block, and one can continue with the surgery. Then lens is placed in the bag, and the surgery, then the patient is sent for the retinal surgeon for doing the vitrectomy. So another case is a post-vitrectomized eye. You can see altered glow here, and this is because of the residual gas bubble which is still there. This is actually a C3 effect, and it made the surgery really challenging because we know that the gas floats upwards, and in supine position it is just behind the posterior surface of the lens. It is actually basically pushing the lens upwards and making the chamber shallow and making the surgery very difficult. So I called the retinal surgeon for help. He came, and with 30 gauge needle in one hand, he's trying to aspirate it, and with the other hand he's aspirating, he's injecting fluid in the vitreous cavity so as to prevent any hypotony, profound hypotony. And now you can see that the residual bubble is being aspirated, whatever minimum amount possible. Simultaneously, fluid is being injected from the other side. Checking the firmness of the globe, eye is found to be firm, and then I continue with the surgery with placing iris hooks. But still, the bubble was there, which is hampering my view. Definitely, I proceeded carefully with phacoemulsification, lower parameters. But during cardiac aspiration, you can see that the PC is bulging forward. There is too much of PC bulging from behind because the air bubble is there just behind, pushing the PC forward. And even with lower parameters, I was really scared to do. Anytime anything can happen. So I called the retina surgeon for help again. So he came and aspirated. So I also feel that there can be a component of fluid misdirection in this case as well. So here the retina surgeon came, and because in this case, without removing the air bubble, I will not be able to inflate the bag to please the lens. So there's a retina surgeon aspirating the air bubble. Sorry for the decentered view. And now you can see that the bubble can be displaced, and I could inflate the bag with viscoelastic. And then I could please the lens in the capsular bed and can finish the lens, the case. So to conclude, to deal with these kind of cases, one should have a better understanding about the phaco machine and its parameters. And I feel that this kind of cases should be dealt by the experienced surgeon available on that day, because successful cataract surgery in these patients is very important to restore their vision and to give the retina surgeon to have a clear view to monitor the posterior segment in future. Thank you. Thank you for your patient listening.
That was wonderful, Dr. Manas. I would like to ask you one thing. How will you manage a case of lens touch during PPV, first planar vitrectomy?
So you have to have, thorough slit lamp evaluation. Here we have to do, as I have shown in the picture, you can have a linear opacification kind of thing. And sometimes if you know the retina colleague, you can ask directly whether you landed up in some complication or landed up in some touch with the instrument, with the lens, or with the instruments. And you should evaluate through that. Not only slit lamp evaluation, there are other newer gadgets like AIOC can be used, or even ILMS 700 can be used if there is no total cataract. And you should proceed with the case as we will proceed in a case of posterior polar cataract. No hydrodissection, only delineation, avoid any chamber collapse. Whenever you're taking out the instrument, put viscoelastics, like that.
Okay.
There can be a PC dehiscence, there may not be, but you have to deal with any lens touch like you are dealing with a posterior polar cataract.
Okay. So any case that you have where you are in a doubt that maybe there may be a PC dehiscence, so we'll manage as we manage a PPC,
definitely,
as you said.
definitely.
Okay. So any questions from the audience for any of our instructors, co-instructors?
Will you consider hydrating the site?
Not required. Now in high-end machines in a saturated light, we don't require it. The active fluidity system is already managed.
So the high-end machine is not there.
Not there. And you have to, if you are using a lower-end gravity based, then increase your bottle height, increase your AFR. More fluid is.
Will you consider another site?
That is I already told. If it is too much leaking, like my video, then you can just stop it and make another parasitic of the site for use that one.
And using viscoelastic is more important last piece.
Yeah, that will.
Yes, and it's actually a good practice. No, when you are removing the last piece, it's better you go for viscoelastics. Even if there is no PCR, just try to make your left hand more maneuverable so that you can use it, and then that can be a helpful practice when you actually have a PCR. Because sometimes injecting with your left hand, no, it becomes very difficult when you actually have a PCR. And also, I would like to know that suppose not the side port, we have a leak through the main wound. So a gross leak, and we don't have a high-end machine. So how do we go about with those cases?
If we have a main port incision,
Leak, yes.
then the machine doesn't work.
Yes, yes, yes.
If you give us the difficulty. If we are, then the sleep becomes important. if we are using a 2.2 mm or 2.8 mm. So in a 2.2 sleeve, we cannot do it in a 2.8 mm incision. So then in case we have to give us this
Suture. Yeah, we have to suture. Yeah. Any other questions?
We like to hear some tips about the anterior vitrectomy. While doing the anterior vitrectomy, the chamber must be closed. Bimanual technique is more important. And the direction of the irrigation port. Direction of the irrigation port should be away from the rent. This is also important. And the direction of the vitrectomy port, it should be headed up so that you can see what you are cutting. These are the things, the important things. I think to be added.
As I have just showed in the animation that you could see, the irrigation port is always above your vitrectomy cutter. Okay, it's not nearby. If you go near, it will be more or less like the coaxial. And why we are saying that no to the coaxial? Because you are hydrating the vitreous. So always the irrigation is above, and you have the vitrectomy, the cutter at this position where you have the rent, the PCR. Okay, and the movement of the cutter is not allowed until and unless you are in position 2. Only when you are cutting, then you can move your hand. Otherwise, you have to. Yeah.
Not go more towards the wound ruptures, right? But then pull the vitreous more. So because the cutter should not be very near the PCR part. Pull the more.
Yes.
Post misdirection syndrome and shallow anterior chamber. What's your strategies to manage such a case? You have got a shallow anterior chamber. You cannot just wait, giving mannitol and waiting for another half an hour and continue going.
So like if it is a non-vitrectomized eye, then probably, I mean, I've faced these kind of cases many times. You cannot proceed. I mean, whatever you do, definitely you cannot put viscoelastic. Even if you put viscoelastic, iris will come. You have to wait, give it time. If you have another case, do that case. In between, you give mannitol, let the eye settle down. And then probably after 10-15 minutes, automatically when the vitreous has shrunk down, you can continue the surgery with all the lower parameters. The vitreous tap, sometimes some people suggest that one can go and remove some of the vitreous through the after doing vitreous tap. That can be done.
One thing I want to add here, like in some type of cataract, like intumescent cataract, where there is a high intralentricular pressure, in that type of cataract also we get a shallow anterior chamber. So in that type of cases, what we can do, we can just pre-operatively just do a vitreous tap, and this will really help to reduce the shallowness of the anterior chamber.
Yeah, but some retinal surgeons don't advise for like vitreous tap in all cases. Like I don't know. I mean, the retinal surgeon can.
But for doing vitreous tap, you should be double so let's say fluid direction. If it is supraparietal hemorrhage.
Yeah.
Yes. And another good point that Dr. Manas has showed in his video actually is that even if you don't have a reverse pupillary block, what he did, lifting up with the second instrument, that can be a very important point, because that will help us to prevent what was shown in the next video, the reverse pupillary block. You tend to prevent it.
Because I know that it is going to happen, so why let it happen? I mean,
exactly.
Okay.
Okay, if we are done with the question answer session, maybe that's the end of our instruction course, and I think we have completed ahead of time. So I would like to ask my co-instructors to kindly come up for a group photograph, please.